Okay, let's dive right in. Every single year, we're talking about something like 300 million people globally needing end-of-life care.
Wow.
Yeah, it's a staggering number when you think about it. And just here in the US, it's around 2.5 million annually.
Mm.
That figure probably hit 3 million a few years back, and it's only expected to climb, with the aging population and more chronic illness.
It really does put a spotlight on just how critical this phase of care is and how many people it touches.
Absolutely. And within that, there's a really specific area we need to talk about: skin and wound care.
Yes, a hugely important aspect.
Which brings us to today's deep dive: palliative skin and wound care. We're drawing everything today from Wound Care Essentials, Practice Principles, specifically that chapter.
A foundational text.
Now, usually when we think wound care, we think healing, right?
Yeah.
Get it closed up.
That's the default, yeah. But palliative care takes a different approach.
Explain that a bit. What is palliative care at its core?
Well, fundamentally, palliative care is all about improving the quality of life. For patients, yes, but also for their families when they're facing these life-limiting conditions.
So improving quality of life. How?
It's about preventing and easing suffering through really early identification, good assessment, and treating pain and other symptoms effectively.
Okay. And palliative wound care applies that same philosophy.
Exactly. It applies those principles to wounds that, well, they just aren't healing as someone nears the end of their life.
So the goal isn't healing anymore.
Right. The focus shifts dramatically. It becomes about comfort, about dignity. Our source puts it really well. The skin, like any other organ, can fail.
That's a powerful way to think about it. Expecting skin to heal when other major systems are shutting down might just not be realistic.
Precisely. And that's why a team approach is so vital here.
A multidisciplinary team.
Yes. Doctors, nurses, wound specialists, others all working together. Making that shift from let's heal this to let's manage this for comfort needs careful thought.
And it has to align with what the patient actually wants, I imagine.
Absolutely crucial. It has to be based on the determination that the wound is non-healing and that this palliative approach fits the patient's goals and values.
So for listeners, our focus today isn't on how to make wounds disappear. It's about tackling the unique challenges when healing isn't the main objective.
It's about understanding how to manage symptoms, maintain comfort, and protect dignity in these really difficult situations.
That's our mission for this deep dive then: understanding how to best manage skin and wounds when cure isn't the goal. Comfort, symptom management, dignity.
And it's so needed because the scale of this problem, it's quite
How
significant.
significant are we talking?
Well, consider this. In the U.S., over a third of hospice patients, that's out of nearly 1 million people, have wounds.
A third. And that's just hospice patients.
Exactly. That doesn't even count people nearing end of life who aren't in hospice care. And get this, over 40 different types of wounds have been identified in advanced illness.
40 types. Wow. That really highlights the complexity, doesn't it?
It does. And interestingly, while we know it's a big issue, the actual research specifically on end-of-life wounds is, well, somewhat limited, especially outside of cancer.
That's surprising, given the numbers.
It is. But the data we do have, mostly focusing on pressure injuries, you might still hear them, called pressure ulcers, gives us a good picture.
Okay, so what does that data show?
Studies from the U.S., Europe, Canada, they show the incidence, meaning new cases, is somewhere between, say, 6.5% and 17% in end-of-life patients.
And prevalence. How many have them at any given time?
That range is even wider, from 9% up to over 60% in some studies, though the average seems to be around 8%.
60%. That's incredibly high in some settings.
It is, but it's important to note, most of those reported were actually stages 1 and 2, the less severe ones.
Okay, so not always the deepest wounds, though still a concern.
Right. But then you look at a 2005 study of home hospice patients, average age 72, mostly cancer diagnosis.
What did that find?
Prevalence there was 15% to 27%. And interestingly, cognitive issues were the main co-occurring problem.
And other studies?
There was a cross-sectional one in hospice patients. Found 35% had some kind of skin wound.
And were those pressure injuries?
Half of them were. And notably, those were often more advanced stages 3 and 4, sometimes with necrosis, tissue death, even gangrene.
That sounds grim.
It led the researcher to call wounds at the end of life a problem of tragic proportion. So yes, while some are less severe, others are very serious indeed.
It paints a stark picture of the burden. And I remember the source mentioned the NPIAP consensus.
Yes, the National Pressure Injury Advisory Panel.
Right.
Back in 2014, they acknowledged something really key. Not all pressure injuries are avoidable. especially at the end of life.
That seems like a really important point for clinicians and families.
It absolutely is. The 2019 international guidelines also give recommendations, many useful in palliative care.
Yeah.
But, the specific research for this group, it's just not as robust.
So a lot is based on best practice and lower evidence levels.
Exactly, given the circumstances.
Okay, so it's a major issue. Let's get into why. What makes individuals at the end of life so vulnerable to skin breakdown?
It's really a combination of factors. Aging itself is a big one.
How so?
Well, as we age, our skin changes naturally. It gets drier, thinner, more fragile. Healing slows down. The epidermis, that outer layer, is easier to damage. Less collagen means less elasticity.
So the skin just isn't as tough.
Basically, yes, its resilience is diminished.
And the source mentioned other conditions too, like dyspnea, anorexia, cachexia, shortness of breath, poor appetite, wasting.
Right. Those can seriously impair someone's ability to sense things. If you're struggling to breathe or have no appetite, you might not notice pressure building up.
That makes sense. Plus the external forces, pressure, shear.
Exactly. Those forces deform the skin. And everyone's skin has a different tolerance level. Sometimes, even with good care, underlying health problems just overwhelm the skin's ability to cope.
So it's internal vulnerability meeting external stress. And you mentioned many risk factors are non-modifiable.
That's a key point. We can't turn back the clock on aging. We often can't fully reverse the underlying diseases.
Which leads us to look at the modifiable risks, or at least the ones we manage. Immobility seems like a huge one.
It's probably the most significant single risk factor. When someone can't move much, especially at the end of life, pressure builds up on certain spots.
And that cuts off blood flow.
Yes, it leads to tissue ischemia. Not enough oxygen getting to the tissues. The risk goes up with age, other illnesses, and pain that limits movement.
Is there a way to measure immobility?
Not really directly, no. We tend to rely on clinical observation. Are they bedbound, chairbound? Can they walk at all?
And what does that lack of movement actually do to the body physiologically?
It causes blood flow to get sluggish, vascular congestion. It can lead to deep edema, that fluid buildup. Muscle strength drops quickly. Oxygen transport can be affected.
Making people feel short of breath, less able to do anything.
Exactly. And the really vulnerable spots for pressure are usually heels, the sacrum, the tailbone area, and elbows.
So what can be done for those specific areas? Heels, for instance.
Suspending the heels completely off the bed helps, using pillows or special heel protector boots.
And repositioning. I hear turn every 2 hours. But is it that simple?
That's a general guideline, maybe every 2-3 hours. But it has to be individualized. You have to consider the person's comfort, their medical stability, the type of mattress they're on.
Right, because repositioning itself can be difficult for the patient.
Absolutely. If someone's blood pressure is unstable, or they're in a lot of pain or nauseous, they might not tolerate frequent turns or certain positions.
So you have to balance the benefits with the burden.
Precisely. And always, always honor the patient's choices. Explain why you're suggesting something, but respect their wishes and involve the family in that conversation.
Okay, let's talk friction and shear. They often come up together. What's the difference, and how do they cause damage?
So shear is like layers of tissue sliding over each other. It distorts the tissue and blood vessels. Friction is just the resistance when two surfaces rub together.
And when they happen with pressure?
They work together, synergistically. They distort the tissue even more, speeding up breakdown.
How can we minimize that, especially for someone in bed?
Using lift sheets is crucial for moving people, rather than dragging. Overhead trapezes can help if the person has some up-and-body strength.
What about protecting specific spots, like the tailbone?
Applying dressings can help. Thin films, silicone dressings, foams, hydrocolloids, they create a barrier, reduce that friction.
But there's a conflict sometimes, isn't there, between keeping the bed flat for pressure and raising it for breathing?
Yes, that's a common challenge. Pressure injury prevention often says keep the head of the bed low, 30 degrees or less, to minimize shear. But someone with breathing problems might need to be more upright.
And even 30 degrees isn't perfect.
No, even that slight elevation can increase pressure between the skin and the mattress. That's where specialized pressure redistributing mattresses or beds can really make a difference.
Makes sense. Now, nutrition and hydration, obviously vital. How do they specifically affect skin at the end of life?
Well, as the body naturally slows down, the need for food and fluid often decreases. People might not feel hungry or thirsty.
Leading to dehydration.
Yes, and dehydration makes the skin lose its elasticity, its turgor. It becomes more fragile. Then there's protein intake. If that drops, you can get malnutrition, protein wasting.
And low protein affects fluid balance, too.
Right. Albumin is a key protein in blood. Low albumin means fluid can leak out of blood vessels into the tissues, causing edema or swelling. That impairs blood flow to the skin.
And the wounds themselves can make things worse.
Definitely. Draining wounds lose fluid and protein. Plus, swallowing might become difficult near the end of life, increasing aspiration risk. So getting enough orally is even harder.
It sounds like a vicious cycle. Families must worry when their loved one isn't eating or drinking much.
They do. And it's so important to educate them gently about this being a natural part of the dying process to ease that anxiety.
The source linked malnutrition pretty strongly to pressure injuries.
Oh, absolutely. There's solid research. One big study showed unintentional weight loss increased pressure injury risk by like 147%.
Wow.
Yeah. And inflammation plays a role too. Certain inflammatory chemicals, cytokines, can worsen appetite loss, muscle wasting, and lower albumin production.
So given all that, what's the goal for nutrition and hydration in palliative care? Is it about hitting certain numbers?
Not usually. It's about maintaining adequate nutrition and hydration in a way that fits the person's condition and, crucially, their wishes. Aggressive feeding might not be wanted or helpful.
So more focus on comfort and enjoyment.
Exactly. Liberalizing diets, offering small, frequent meals of things they actually like. Nutritional supplements if tolerated. Quality of life is the driver.
Okay. Lastly, in this section, let's touch on moisture. Too much is bad for skin, right?
Definitely. Whether it's sweat, wound drainage, urine, or feces, excess moisture makes skin much more susceptible to damage.
Incontinence must be a huge challenge then.
It is. Managing incontinence is key to preventing skin breakdown, but also for comfort and odor control. Feces are especially harsh on skin chemically and mechanically.
So gentle cleaning and protection are vital.
Absolutely essential. Gentle removal, applying skin protectants. Sometimes containment devices like catheters or fecal management systems are needed to protect the skin long term.
And the source mentioned performance scales, like Karnofsky.
Yes, lower scores on those scales, indicating lower functional ability, are common at end of life. And a low Karnofsky score has actually been linked to higher pressure injury risk in home palliative care.
Okay, we've established the scope of the problem and the risks. Let's shift to treatment. What are the main goals in palliative wound treatment?
The goals are really threefold. 1, prevent wounds if you can. 2, stabilize existing ones, maybe even close them if that's feasible and fits the overall picture.
And the third?
And most importantly, manage the symptoms: pain, odor, exudate, bleeding. The overarching aim through all of this is enhancing comfort, well-being, and quality of life.
How does that differ from standard wound care, where healing is the main goal?
The core difference is the goal. The techniques we use, dressings, infection control, might look similar sometimes, but the objective shifts from cure to palliation, meaning symptom relief and comfort.
And that shift happens when?
It becomes the focus when a wound just isn't healing despite good care, or when the patient's overall condition declines to where curative approaches aren't appropriate or wanted anymore.
So symptom management becomes paramount. How do we maintain skin integrity in that context?
Well, as we've said, the body's ability to cope is impaired at the end of life. Skin perfusion decreases, there's less oxygen, the immune system is weaker. That's why not all breakdown is preventable.
And lack of oxygen hinders healing anyway.
Exactly. So you need ongoing, comprehensive assessment and a solid care plan. Frequent skin checks, especially over bony areas. Addressing nutrition and hydration as best you can. Managing other skin issues.
What are the practical day-to-day things caregivers can do?
Key strategies include that risk assessment, really meticulous but gentle skin care, positioning and repositioning when tolerated, reducing friction and shear, using the right support surfaces, nutrition hydration focus, and managing moisture.
Cleanliness is important too, I imagine.
Hugely. For comfort, infection prevention, and odor control. Using pH-balanced cleansers, moisture barriers is good practice. Gentle cleansing, especially in prone areas.
Like a massage.
Avoid vigorous massage over red areas that can cause damage. But gentle overall body massage can be very comforting if there are no contraindications.
And moisturizers.
Yes, emollients help maintain moisture. Skin protectants, especially barrier products for incontinence, are crucial.
The source had a practice point, summarizing the key focuses. What were they?
Pain management, odor control, exudate management, bleeding control, addressing self-image concerns, preserving dignity, and enhancing quality of life. Those are the guiding stars.
Okay, let's talk assessment and palliative care. How does it differ?
It's still head to toe, but it needs to go beyond just the physical. You have to assess psychosocial well-being, quality of life, too.
Why is that broader assessment so important here?
It helps the team realistically evaluate, is prevention needed? Is closure even feasible? It identifies current risks and wounds, but also future risk, considering the whole clinical picture.
What specific things need to be assessed?
Comorbidities, medications, risk factors, nutritional status, any diagnostic tests, psychosocial factors, available resources, and critically, the patient's and family's goals.
Is there a specific risk tool for palliative care?
Yes. The Pressure Sore Risk Assessment Scale for Palliative Care, sometimes called the Hunter's Hill Scale.
What does it look at?
7 things: sensation, mobility, moisture, activity level, nutrition, weight change, skin condition, and friction shear. Get score lower means lower risk, higher means higher risk,
How often should that be done?
maybe weekly, or if the patient's condition changes significantly. Though near the very end, you might adjust frequency to prioritize comfort.
And assessing the wounds themselves, what do they typically look like?
They're often chronic because healing is impaired. You might see well-defined borders, non-blanchable redness around them, maybe hardened tissue, or rolled under edges.
Rolled edges, why does that happen?
Often happens if the wound bit is dry. It's the wound trying to conserve moisture, but it actually hinders healing. Drainage is common, and in chronic wounds, it can contain enzymes that aren't helpful.
So even if healing isn't the goal, assessing the wound regularly is still vital.
Absolutely. Initially, with dressing changes, at least weekly, unless someone is actively dying, you need to set goals aligned with patient values and reassess progress towards managing symptoms.
And skin assessment in general.
Comprehensive skin assessment should happen soon after admission as part of risk assessment, directly based on risk level and before discharge.
Okay, let's circle back to support surfaces and repositioning in this context.
Support surfaces, special mattresses, cushions, redistribute pressure. You need to match the surface to the individual's needs, spreading weight out, especially over bony beds.
And repositioning schedules.
Individualize it. Base it on pain tolerance, comfort. Regular repositioning is still generally good unless contraindicated, but the schedule needs to consider skin tolerance, medical condition, comfort, pain. It's a balance.
What about evidence-based practice for nutrition in palliative patients with pressure injuries?
The recommendation is clear. Develop and implement an individualized nutrition care plan if someone is malnourished or at risk, tailored to their needs, preferences, and overall goals.
Pain management, hugely critical in palliative care. How does wound pain show up here?
It's significant. Both prevention efforts and treatments can be painful. Most patients with pressure injuries report moderate to severe pain, especially during dressing changes or procedures.
Is it constant pain or just during procedures?
It can be both. Acute pain during procedures, but also chronic background pain. It can come from tumor pressure, exposed nerves in the wound, the procedures themselves.
Like removing a stuck dressing.
Exactly, especially if it's dried out. Since pain relief is a primary goal, regular thorough pain assessment is non-negotiable.
What tools are good for assessing that pain?
Several validated ones: VAS, Visual Analog Scale; VRS, Visual Rating Scale; Numeric Rating, 0-10; the FACES Scale, FLACC for nonverbal patients; and the McGill Pain Questionnaire. Studies confirm VAS, FRS, and MPQ work well for pressure injury pain.
Okay, so how do we manage the pain? What are the options?
Pharmacologically, mild to moderate opioids, sometimes mixed with hydrogel, non-opioids, topical anesthetics like lidocaine. There are even ibuprofen foam dressings in some places.
And compounds?
Some palliative care units make their own topical mixes for pain and odor. Minimizing procedural pain is also key.
How?
Gentle cleansing, using low-pressure irrigation, warming products before applying them, avoiding harsh antiseptics.
And non-drug approaches.
Absolutely. Music, relaxation techniques, position changes, meditation, guided imagery, touch therapy, distraction, they can all help.
And that practice point about pre-medication.
Crucial. Give appropriate pain medication 30 to 60 minutes before dressing changes or procedures. Plan ahead.
Makes sense. Let's talk dressings. What guides choices in palliative care?
Ideally, choose dressings that can stay on for several days if possible. Minimizes disturbance.
What else is important?
Good protection for the surrounding skin from moisture or contamination. Good protection for the wound bed itself. Generally, non-adherent types, foams, polymeric membranes, silicones, often good choices.
And maintaining moisture.
Usually, yes, a moist environment helps prevent nerve ending exposure, which produces pain. Dry wounds often hurt more. Diamorphine hydrogel has shown effectiveness for pain in open pressure injuries in palliative care.
Okay, infection, odor, exudate, three big challenges. How do we tackle those?
Well, tissue that lacks oxygen and nutrients can die, becoming necrotic. That's fertile ground for bacteria.
And bacteria plus dead tissue equals odor.
Often, yes. Especially anaerobic bacteria, they tend to produce stronger smells. Effectively managing odor, drainage, and pain is critical because these are often the most distressing symptoms for everyone involved.
Odor especially can be isolating, right?
Hugely. It can lead to social withdrawal, shame, depression. So strategies focus on removing the source and managing the smell.
Like what?
Frequent dressing changes, maybe secondary dressings to contain odor, frequent irrigation, topical metronidazole gel, or crushed tablets for anaerobes.
What about removing the dead tissue, debridement?
Important for odor and infection control. Autolytic debridement, using the body's own enzymes, is often least painful. Sharp debridement needs caution due to bleeding pain risk.
Any specific dressings for odor?
Activated charcoal dressings are excellent. Silver dressings, cadexomer iodine, povidone iodine can also help manage bacteria and odor. Even things like medical maggots can be very effective in some cases.
Anything else? Room deodorizers?
Yes, those can help. And topical sugar paste or medical honey have antibacterial and debriding effects too.
And managing the exudate, the drainage.
You have to protect the surrounding skin from getting waterlogged, macerated. That leads to more breakdown and itching.
So absorbent dressings.
Right. Alginates, hydrofibers, foams, non-adherent pads. Choose based on the amount of drainage. Change them when they're saturated.
What if there's very little drainage?
Then maybe lower absorbency dressings like hydrocolloids or films are better. And barrier films on the surrounding skin add extra protection.
Selecting dressings sounds complex.
It involves considering the patient's goals, their ability to manage dressings, and the wound itself. But controlling odor is absolutely vital for quality of life.
And the exudate itself can tell you things.
Sometimes, color and smell can hint at bacteria type. Greenish drainage might suggest gram-negatives, maybe treatable with silver. Persistent inflammation or infection increases exudate, and that protein loss can worsen malnutrition if oral intake is poor.
Let's pivot to specific wound types often seen in palliative care. Fungating wounds first. What are they?
They happen when a tumor breaks through the skin, infiltrating blood and lymph vessels. This starves the tissue, leading to necrosis.
How common are they?
Affect maybe 5% to 19% of metastatic cancer patients, more common over 70, often seen in the last months, but can be present for years. Breast cancer is a common primary site, also head, neck, melanoma areas.
Why fungating?
Describes the growth pattern, often ulcerating, like a crater, and/or proliferative, like nodules, sometimes resembling a fungus or cauliflower. Skin tumors tend to ulcerate easily because of surface bacteria and compromised tissue.
What are the main symptoms?
Lots of exudate, often foul-smelling, pain, itching, bleeding, and significant psychosocial distress for patient and family. Emotional support is key.
Do they heal?
Very rarely. So management is all about symptom control, comfort, quality of life. It's complex, needs good teamwork and communication.
The source used the acronym HOPES for managing them.
Yes, HOPES. H is for hemorrhage or bleeding. It's the most common emergency.
Oh, why so common?
Tumor erosion of blood vessels, low platelets, tissue necrosis after radiation. The tissue is very fragile. That's why non-surgical debridement is preferred.
How to minimize bleeding?
Use non-adherent or soft silicone dressings. Keep the wound moist. Gentle irrigation, no harsh swabbing. Avoid dry dressings that stick. Be cautious with alginates on fragile tumors.
Are there things to stop bleeding?
Yes, topical agents like collagen, oxidized cellulose, silver nitrate sticks, epinephrine, sucralfate, surgical sponges.
Okay, H is hemorrhage. O.
O is odor. We discussed dressings for that. Alginates, foams, charcoal. P is pain. Pain again, regular assessment, multimodal management. E is exudate, managing drainage to protect skin, control odor. SS is superficial infection. Common, manage with topical antimicrobials, clean environment.
All right, next specific type, radiation wounds. How are they different?
Radiation therapy targets a specific area. While it aims deep, the overlying skin gets hit too. Skin reactions can happen during, right after, or even years later.
What do those reactions look like?
Redness, flaking, peeling, pigment changes, hair loss, less sweat, visible blood vessels, swelling, ulcers, scarring. Acute wounds might be red, maybe draining sinuses.
What's happening at the cellular level?
Radiation impairs healing. It causes skin thinning, blood vessel blockage, excess scar tissue, fewer healing cells, direct cell damage. Most lesions are superficial, though.
Is there a grading system?
Yes. The Oncology Nursing Society has 0 to 4, from no change to full-thickness necrosis.
How do you treat them?
Similar principles to other wounds. Keep the area clean, moist, protected. Avoid tight clothes, adhesives, harsh soaps, sun, heat, trauma.
What about specific treatments?
Minor reactions like redness or dry peeling might get hydrogel or mild steroid cream. Moist peeling, similar treatment, plus non-adherent or foam dressings. Covering helps pain, prevents infection.
And severe ulcers.
Manage like other open wounds with moist healing. But first, rule out new cancer. Sometimes skin grafts or growth factors are considered.
Are they prone to infection?
Yes, your radiated tissue has poor blood supply, less oxygen, so it fights infection poorly. Topical antibiotics might be needed. That poor blood supply also causes pain. They're tough wounds, slow to heal, often need systemic support.
We've covered so much detail. Can you give us a quick summary of the key takeaways for palliative wound care?
Absolutely.
Yeah.
The main message: cure might not be realistic, but compassionate, symptom-relieving care is. It's about balancing wound symptom management, pain, odor, exudate, bleeding, with preserving dignity and maximizing quality of life.
Even though the research base isn't huge.
Right. There's still limited high-level research, but consensus documents like the International Palliative Wound Care Initiative offer good guidance. We need more study on when to shift goals and how to build comprehensive programs.
But even without healing as the goal, care makes a difference.
Definitely. Appropriately treated wounds can show marked symptom improvement in many cases, even in hospice. It absolutely makes a difference.
The source had a patient scenario, Mr. M, to illustrate this. Can you walk us through that briefly?
Sure. Mr. M, 86, widower, end-stage cancer with bone mets, at home on hospice. Eating very little, losing weight, wanted to stay home.
And his wounds?
Stage 3 pressure injury on his left hip, moderate exudate odor, and a stage 4 from a medical device on his left ear.
What were his preferences?
He strongly wanted to stay in his own bed. Refused special overlays like sheepskin or air mattresses. His goal was simply comfort.
How did the hospice nurse handle that?
Assessed his and the family's goals carefully. Honored his wish to stay in his bed, even though it wasn't ideal for pressure relief. They compromised on repositioning more frequent turns off his preferred left side. Used heel protectors, pillows,
And wound care.
gentle cleansing, a composite dressing for the hip, foam for the ear, charcoal pouches under the bed for odor, skin protectant on other bony spots.
What about food and pain?
Offered small amounts of things he liked: high-protein liquids, popsicles, ice cream. Non-opioid pain med before dressing changes encouraged him to ask for breaks.
What was the outcome?
The hip wound got slightly bigger, but that was within the palliative goals. The ear wound didn't change. Most importantly, Mr. M felt he got to have things his way. He was appreciative.
That really underscores the patient-centered focus, doesn't it? Comfort and wishes taking priority.
Exactly. It's a perfect illustration of palliative principles in action.
So wrapping up, the core message really seems to be, in palliative wound care, the focus shifts decisively. Away from healing, towards enhancing comfort, managing those tough symptoms, and always, always preserving dignity.
That's the heart of it. And that leaves us with something important for you, our listener, to think about. Given how many people need end-of-life care and how common wounds are, how can our healthcare systems get better at integrating these palliative wound care principles? How do we make sure resources are there to ensure the best possible quality of life?
And the ethical side, too.
Yes, what are those ethical considerations when we prioritize comfort over cure in wound management? Really vital questions as we aim for truly compassionate end-of-life care.